going? It's good to see you. Listen, while you're here, can I bend your ear about something just for a second? I know that there's a ton of you docs out there that are doing great works in your emergency department, changing things for the better and everything like that. But the issue is that I'm having a real hard time reading about your efforts, even if they've failed. And I'd like to know, I'd like to figure out if I can do that in my own shop. And so, if you have a project that you're involved in that is improving the safety or equity or effectiveness or even the timeliness of the care that you're delivering in your emergency department, we at the Canadian Journal of Emergency Medicine, we want to hear about it. So reach out. Send us an email at cgem@caep.ca. And we'd love you to submit your articles under the QI stream so everybody else can read about them. And that goes for you medical students, residents, and even you researchers out there. We want to hear from you. Anyhow, thanks for your time. Back to some light reading.
Hi, everyone. First of all, I would just like to say thank you, Sean, for that great video promoting QI research in emergency medicine. And going forward, welcome to the first resident organized trauma-informed care rounds. Let me just figure out some technical difficulties here. Okay, we're good. So first, let me introduce myself. My name's Jess. I'm one of the PGY2 emergency medicine residents at the University of Toronto, and I'm currently sitting on the CAEP resident executive as the CGEM resident editor. Tonight, I get the pleasure of being your moderator and MC on behalf of the resident executive, and I get to help lead the panel discussion on our grand rounds of trauma-informed care. And again, this is our first resident organized grand round, so thank you all for coming. We're very excited. We have 4 really amazing speakers on our panel this evening, and without further ado, let me get started introducing them. So first up, we have Miss Rachel Bromberg, a peer supporter and patient advocate in her role as co-founder of the Reach Out Response Network, which is a mental health emergency medicine response network in Toronto, Ontario. Rachel, can you tell us a little bit more about your role?
Yeah, so the Reach Out Response Network is an advocacy-focused mental health nonprofit that is working with the City of Toronto to develop and integrate a non-police mental health emergency service. And our organization is also the anchor for the International Crisis Response Association, which is a service providers network connecting folks across Canada and the United States who are building or leading similar services in their communities.
Thank you, Rachel. We're so lucky to have you tonight. Next on our panel, we have Dr. Carrie Samsel, an emergency physician and medical director of the Ottawa Hospital Sexual Assault and Partner Abuse Care Program. Dr. Samsel, can you tell us a little bit more about your role?
Hi, Jess, and thanks for having me on here tonight. I am the medical director of the Sexual Assault and Partner Abuse Care Program here at the Ottawa Hospital in Ottawa, Canada. I'm also a staff emergency physician at the same place. And so my role encompasses holistic medical and forensic care for survivors of sexual assault, intimate partner violence, and human trafficking. And part of my role includes education, policy work, research, and advocacy.
Great. Again, so lucky to get to have you on the panel tonight. Thank you for joining us. Our next panelist, Dr. James Liu, is an emergency and primary care physician who provides care to First Nations communities in central and northern BC, in addition to many other things. Dr. Liu, can you tell us a little bit more about your role?
Thanks, Jess. Hi, everyone. Thanks very much for having me. I'm James Liu. I'm one of the emergency physicians in Langley, BC, and as well as a few other community and regional sized emergency departments. I also work with a nonprofit organization that works with, that's Indigenous led and works with Indigenous communities throughout central northern BC as part of an interdisciplinary primary care team. Performing outreach to these communities and following people longitudinally, which has many interesting connections both locally, but also with the work that's in the regional hospital emergency department, so that we can begin to build some linkages locally. And so that's been the focus of my work around Indigenous health and social emergency medicine.
Perfect. Thanks. Again, so great to have you on the panel. And last but certainly not least, we have Dr. Kate Heyman here with us, an emergency physician at UHN in Toronto, who also works in the Inner City Health Associates at the COVID Recovery and Isolation site, providing social and medical isolation supports for people experiencing homelessness. Dr. Heyman, could you please elaborate further on your role?
Thanks so much, Jess, for having me, and to the residents for the invitation. So I work, as Jess said, with Inner City Health Associates at the COVID Recovery and Isolation site. So we provide supported isolation in a multi-partnership team with social harm reduction, shelter workers, healthcare workers, including nurses and physicians, and try to utilize a trauma-informed approach to supporting folks who oftentimes have experienced a lot of trauma, particularly in the healthcare system. And I'm really excited to talk a bit more about how my perspectives working with folks experiencing homelessness and folks who use drugs has informed my practice in emergency medicine.
Perfect. We're excited as well. So, as you can see, everyone, we have an amazing array of experience to inform our panel discussion tonight. First, some organizational things. As I mentioned, the CAEP executive has put together this rounds, and we've all kind of come together with some questions in collaboration with our experts here in order to address the objectives that we've sent out in the email. So basically how it'll go is I'll pose these questions and we will get to hear from our expert panelists. And then any questions that you have, we'd love to hear from you. Just fire them up in the chat. And what we'll do is, closer to 10, 15 minutes near the end of our presentation tonight, we'll start going through those after our stated questions. Just a reminder, the goal of our session is to provide an understanding of trauma-informed care and really walk away with some practical tools to start using on the next emerge shift. Some last minute housekeeping things to go over. First of all, the Scientific Planning Committee has reviewed all of our declaration of conflicts of interest, and there's no conflicts perceived or real. And there's no kind of external support received for this webinar, nor I or anyone else on this panel is getting paid to be here. Additionally, from a credits perspective, attendance certificates and evaluation link will be sent out to you guys on Thursday. We encourage everyone to complete the evaluation, which will be sent to you so that we can continue to bring you guys really great content through the National Grand Rounds presentations. So without further ado, let's begin the panel discussion with our first question. The first question I will be directing first towards Rachel and then towards Dr. Carrie Samsel. So, can you please provide a definition of trauma-informed care for those working in the ED? Rachel, as I mentioned, we'll start with you.
Great. So trauma-informed care is basically recognizing different types of trauma that people may have experienced in their lives. And often when doctors think about trauma, they're thinking about physical trauma that people might have experienced, but also recognizing interpersonal trauma, like, for example, childhood abuse, domestic violence, racism, poverty, other forms of oppression, and those impacts on people's experiences. And understanding how those past experiences can impact people's behaviors, people's thoughts, people's feelings, and responding to people with that understanding in mind. So adjusting the care that you're providing to accommodate people's vulnerabilities and their experiences of trauma or oppression. Other components of trauma-informed care, assuming that everyone you meet has experienced trauma or providing care with that in mind, because a lot of people who've experienced trauma, especially in an emergency room where they might not know you, they're not necessarily going to tell you immediately, I'm a trauma survivor. They might, but usually they won't. So just approaching people with that in mind, with knowing that it's possible and even probable that your patient has experienced trauma, and educating yourself on trauma, the impacts of trauma on people's lives, recognizing and taking steps to address your own biases and your own blind spots so that you can provide informed care to your patients. I can give some examples of trauma-informed care in emergency rooms or in hospitals. So one thing is just asking people, what will be helpful for them and what do they need in order to feel safe and comfortable as you're providing care for them, especially if someone is in distress, just asking them what they need and doing your best to provide that kind of support. Another thing is, trying to promote safety within your relationship with that person, even if you're only, with them for a short period of time. And one way to do that is just making sure that obviously everything that you do, you're getting consent from that person and just being really clear about what's going to happen next. So, I'm going to put the needle in your arm right here. You might feel a tiny pinch. The needle will be in for just a second. That kind of thing can be really helpful for folks to know what's happening and to be able to consent to each step. Another thing that we do in the hospital that I work at, which is specifically a mental health hospital, is providing comfort items for people who are or who might be in distress. So one of the things that we do is we have like stuffed animals and stress balls and fidget spinners and other things like that available in our emergency room and on each of our units for when people might be getting escalated or agitated. So those are just some examples of care, the trauma-informed care.
Thank you, Rachel. That's really awesome. Especially appreciate the examples. Dr. Samsel, do you have anything to add?
So in my expertise area, sexual assault and domestic violence, it's very obvious to think of those as traumas for people because it is a subset of physical or injurious type of thing that you can have happen. And there's research is out there that says that 1 in 3 people will experience this in their lifetime. So what Rachel had said of saying that people have historical traumas is very true. And those are Canadian numbers. So people you are seeing today, tonight, tomorrow on your next shift are going to be survivors of trauma in some way. Having a positive disclosure response to someone disclosing their trauma to you actually has a 6-fold reduction in things like PTSD, substance use disorders, and declining mental health. And what I mean by a positive disclosure, it's not like, woo, trauma. It's more like, thank you for telling me that. I'm here to help you. What would help you best at this point? So really putting the patient at the center of their care as best as you can. And once again, approaching somebody with care that you're not suddenly going to be like, oh, I'm going to examine your neck and lunging out and trying to touch someone's neck. If they've just been strangled, they're going to be quite standoffish about that. So you want to be very careful and intentional with what you're doing and how you're approaching a patient like this.
Thank you. We'll move on to our next question. I feel like we've got a pretty good, intro to what trauma-informed care and how important it is and how prevalent it is, which was very surprising to me before I started researching into this topic. Question 2, and we've alluded to this a little bit, is what are some of the different ways that our patients in the emergency department can experience trauma? I think we'd all like to hear from a few of you guys on this. Dr. Samsel, perhaps you could continue on a little bit first, and then Dr. Heyman, I'll turn to you.
Sure. So disclosures of trauma or disclosures of violence against someone is not always common. People don't walk in and say, I've been assaulted, I have been oppressed, I've had something terrible happen to me. So making yourself comfortable with asking those kinds of things is very important. It's also important to recognize that people with what we consider to be chronic or repeat presentations for things often have a big interlaced and underlying traumatic event that's happened. So your chronic pain people, your people with long-term headache, your people with substance use issues, people with mental health disorders, there's usually a simmering current of underlying trauma in there too. And if you don't ask something about that, all you're doing is treating that symptom, and you may not actually get somewhere, and there can be a lot of friction between you and your patient as you're trying to get to a common goal.
Yeah, really important. Dr. Heyman, would you like to add anything from your experience?
Sure. And I actually, in answering this, reached out to the peer support team at Toronto General and Toronto Western. And so our peer support workers are a group of people who have lived experience of substance use, mental illness, or homelessness. And they provide support to patients through the lens of their own experience, and really prioritize understanding the whole individual and trying to provide supports in a way that is accessible and appropriate, and trying to avoid triggering. And they might not necessarily use the language of trauma-informed care in what they provide, but very often that's a real focus of their work. And some of the main issues that they highlighted in our emergency departments is a lack of verbal de-escalation. So oftentimes a lot of people who have experienced trauma have had a loss of autonomy, and they come into our emergency departments and we take all of that away very quickly. And oftentimes when people are lashing out or might seem agitated or escalated, it's a way of them demonstrating that they're in distress. It's a learned response, it's an adaptive response, and we respond to their distress by doing something more distressing, which is oftentimes putting people in physical restraints. And I don't want to say that physical restraints are always inappropriate. That's not the case, but I think oftentimes there are many mechanisms that could avoid the use of physical restraint. And that's something that our peers repeatedly comment on. And there is qualitative research that actually discusses like physical restraint is a reason people don't come back to hospitals. So they experience this re-traumatization in our emergency departments, and it may prevent care seeking in the future, which I think is pretty challenging. Our peers also mentioned some things that I think might be less obvious. Some of that is just ignoring people. When people are chronically institutionalized or have experienced a lot of trauma, just not recognizing folks as humans, walking past them when they ask you for water or a drink, and not acknowledging their humanity in that moment can often be very re-traumatizing and give the message that you don't care as their healthcare provider, which I don't think is what any of us are trying to say or trying to show, but that's the way it's understood by our patients. And another thing is not having regard for people's stuff, particularly for people experiencing homelessness, like losing one's backpack or losing one's phone can be very, very stressful, very distressing. And to then have your healthcare providers kind of say like, finding your phone is not my job, it's not my business, can actually make their experience further traumatizing, and you're not recognizing what's most important to them. So those are a few examples that I think really resonated with me and hopefully are helpful.
Yeah, well, thank you. And thank you for reaching out to the peer supporters at UHN. That's a very valuable perspective. And, it's not something that we often think about, certainly, but things we encounter every day. Dr. Liu, do you have anything to add?
Thanks very much. Numerous studies and reports have actually documented some treatments that Indigenous patients are actually more likely to have adverse events in the emergency department above and beyond some of these that have been described. And these may include things like derogatory stereotyping, negative assumptions, or actually overtly rough physical treatments or unacceptable interpersonal interactions. And so these, not only can these interactions come from health professionals across different disciplines, these can also come from other people like other hospital staff or security staff. And while some extreme examples have been reported in the media, there are numerous examples of everyday racism and microaggression that's experienced on a daily basis that usually don't make it out to the media or get documented in any way. And so the recent In Plain Sight report that looked in British Columbia found that Indigenous patients were actually 2.6 times more likely to leave hospital against medical advice than non-Indigenous patients. And so this may reflect people voting with their feet on the basis of these adverse care experiences. And so this overall contributes to the phenomenon of structural violence, where social structures and institutions cause harm by preventing people from meeting basic needs. And the nature of hospital, that's the institutional nature of hospitals and emergency departments can also be re-traumatizing, particularly for individuals who may be survivors of Indian hospitals, residential schools, or the 60s scoop. And so some patients have indicated that the building styles, as well as the authoritative tone and atmosphere that exists in these spaces, can bring back very traumatic memories. And so attendance in the ED may also come with a threat of child protective service involvement, regardless of whether or not that's indicated. And so that can also be traumatizing with or without it actually happening.
Wow, thank you for providing your perspective. And the evidence behind this is pretty shocking. Now that we've kind of talked a little bit about trauma-informed care and the different ways that our patients experience trauma-informed care, I think this leads nicely into question 3, which is something about what can we do about it. So how do we ensure the language we are using in the emergency department reflects the practice of trauma-informed care? The first, Rachel, I'll start with you, and then we'll get some other perspectives on this too. Very important.
Sure. So I guess the first thing that I'll say is like why it's important for us to be using trauma-informed language when we're talking about our patients. So obviously the way that we label people, the way we talk about people and label their behavior influences how we think about them. We want to speak about and to the people that we're working with as equals rather than seeing them as disordered or seeing ourselves as superior to them in some way. Also important to recognize that patients can view their chart. They can read all of the notes that you're taking about them, and that can really impact and damage their trust in you, their trust in the hospital, their trust in the medical system in general, particularly for folks who have experienced trauma or oppression historically. We really want, if someone is reading notes about themselves, that what they're seeing accurately reflects their experience of themselves and isn't derogatory or unnecessarily negative or using inappropriate or stigmatizing language. So language use really matters. I can give some tips and tools for using appropriate language to refer to patients, but honestly, a lot of the language choices that we make when we're talking about patients really come from mindset. If we genuinely view patients as equal partners in their treatment and we really genuinely see them as full people with their own valid needs and choices and desires, even when those might be different than what we think they should be, the way we talk about them will naturally flow from that. So that's just an important thing to keep in mind. But that being said, some things that I've learned just in my work about language. So one of the things is using person first language. So talking about, for example, a person living with schizophrenia rather than saying a schizophrenic, or a person living with depression, or a person who has been diagnosed with borderline personality disorder rather than saying like a borderline or something like that, rather than making the diagnosis the descriptor, making the person the descriptor, and only really including a diagnosis where that's necessary. A lot of the time, especially when we're talking about mental health concerns, it really isn't necessary. Sometimes it is, but in your general conversation about a person, you don't need to constantly be referencing a particular diagnosis. Another thing is terms like low functioning, particularly when referring to people with developmental disabilities or autism. It's not very trauma-informed language. The better language to use is specifying the things that a person might need additional support with, because that's typically when we're using terms like that, is when we mean this person needs additional support with XYZ. So just listing that out. Using terms like treatment resistant or non-compliant or has no insight, instead using terms that describe behaviors. So for example, saying, Sam took his medication only 2 days out of 7 days this week. I know that takes longer to write in a chart, but Sam is going to be a lot happier if he requests your chart and sees that rather than sees medication non-compliant, has no insight into his illness. And it also is more descriptive for your colleagues who might be reading this chart. When they just see non-compliant, they don't necessarily know, they know what non-compliant means, but they don't know what specific behaviors are occurring that are leading you to jump to that conclusion. Similarly, using terms like manipulative, demanding, abusive, aggressive, stuff like that, just describe the behavior again, like Sam did XYZ. Sam hits when he's upset, or Sam hit person X last week, things like that are better than just using derogatory labels to refer to behaviors. Also, as much as possible, using people's own words to describe themselves or their experiences, and focusing on what people are telling you and what their experience have been, rather than framing everything as symptoms. So for example, Sam believes that his neighbors want to hurt him, or Sam believes that person X is in love with him, rather than saying Sam is delusional, Sam is paranoid. It's just better practice for giving more information about what's actually happening, and also sort of taking out language that could be perceived as judgmental.
So many great points there, Rachel. I don't even know which ones to highlight on. Like, really excellent. It's stuff that we see all the time. I can't remember the last time I saw a chart without, at least one of those things. And I think moving, we're dictating now not that it's a great excuse, the cumbersome nature of like writing down things, but now that we're dictating, there's no reason why you can't be more descriptive and use trauma-informed language. Dr. Heyman, do you have anything to add?
Sure. I just like to reiterate like what Rachel said about how much our language matters. And one that really irks me, particularly as someone who's working a lot right now with people experiencing homelessness, is left against medical advice. And I think very often that reflects that, like, as the treating team, we were unable to come up with a treatment plan that actually met the patient or the client where they're at. And sometimes, like, if the person is leaving the ER because if they don't, their pet might die of starvation, or they might lose their job, or they might lose their housing, or they might lose their bus shelter where they usually sleep and feel safe and protected. They're potentially making a decision that's in the best interest of their health. And we're not recognizing their priorities at all in that. We're recognizing our priorities only. So I think figuring out how to convey that, the person understood their current condition, they felt that they needed to go home. Again, what Rachel's saying, like using more descriptive language, they needed to get home to feed their animals, and recognize that if their breathing gets worse, then they will come back to the emergency department. And we do our best to facilitate the safest care plan together with the patient or the client. And I think there may be folks listening to this tonight, maybe not because you came to the trauma-informed care rounds, who are wondering, like, does it really matter? There is evidence that this matters. So there's a nice small study of residents and medical students where they read 2 hypothetical vignettes. One is just using pretty straight descriptive language, and it's a patient with sickle cell disease. And the second vignette uses language like narcotic dependent, frequently in our ER, says he was at McDonald's with his friends, which is an unnecessary sort of descriptor of poverty. Says he refuses to wear the oxygen mask rather than not tolerating the oxygen mask. And in the second case, the residents who read that case had both more negative attitudes to the patient, but they actually treated the pain less well as well. So the prescribing practices differed based on the language that was used in the vignettes. And I think that's a really helpful thing to remember when we're documenting and we're handing over to our colleagues. That frames so much of the encounter, and it changes the treatment that's given. So it really does impact the way that we look after patients.
Thank you. That's a really impressive study. Yeah, treating, reading and the language and the fact that you got your pain treated less, pretty crazy. Dr. Liu, do you have anything to add?
One thing that I reflect on is that it is actually possible to provide care without having the person feel cared for. And so this can come with a variety of different ways. I think that Rachel, Dr. Samsel, Dr. Heyman all mentioned in terms of not seeing and treating people as human. And patients do really feel, experience, and they remember that. And oftentimes in the setting of trauma, pre-existing trauma, trust is often the number one ingredient that we're seeking to build, and that is lacking. And for good reasons, very solid reasons. And at times when we don't convey an active tone to the patient that we are trying our best to meet their needs. We are trying our best to engage with these individuals. We are trying our best to optimize the care outcomes. When we don't actively demonstrate that to people, people don't assume that that's what's happening, and when people may not be able to experience that, especially because some of the general mechanism that someone who maybe experiences may be dulled and impaired because of the experience of trauma. And so people may actually leave without an episode of care being completed, and the provider is happily documenting that, oh, I did this for the patient, I'm planning to order this test, I plan to consult this individual, I'm planning to set this up, and the patient is, has left without these being completed. It looks like the patient is being quite ungrateful or uninsightful, but really, if we don't tell the patient that, like, look, like these are the things that may help, and these are the reasons why it may help meet your needs, and I really want to help set these up for you, and I think, and if we don't convey that, I think we're going to be losing that trust. And what's interesting as well is that research shows that when working with patients of ethnicity other than our own, providers are actually more likely to use less patient-centered and a more biomedical communication style. And sometimes we in addition, we actually are less prone to trying to match our communication style with the explanatory model of the patient, and as well less likely to try to elicit what that explanatory model is so that we can better work with it. We tend to stick to a strict biomedical model, and that can be extremely damaging to trust. And so I think that in addition to the specific words, is also oftentimes the nonverbal and the tone of how we convey. And finally, when responding with agitation, I think oftentimes, just like we said earlier, I think we oftentimes help escalate the situation, either based on indifference or based on other microaggression of our own that we may be contributing to the situation. And as opposed to looking for ways to meet needs, we often exert authority in the emergency department. We often police language. And essentially we create these labels, and we create escalation, and essentially we convince the patients that regardless of what they do, their needs will not be met. And so patients will become more and more agitated for understandable reasons. And so again, I think our in addition to our words, our behavior also matters.
Thank you for that. I think we've got a really comprehensive picture of how important the language you use is, and using language as an intervention to provide trauma-informed care. Thank you everyone for your answers on that. I think that this is a nice segue into our fourth question of the night, which is, why is trauma-informed care essential in the care of Black, Indigenous, and the people of color in our communities? And I'm going to ask Dr. Liu if you could provide some further insights on this.
Sure. The urgent nature of an emergency medicine encounter can oftentimes exacerbate the power differential in that the person coming in has symptoms, has acute presentations now. And so that can, that urgency can exacerbate power differential in the physician and patient's communication and patient-physician relationship. And so given the context of historical trauma, some Indigenous patients may be disproportionately disadvantaged in these encounters for that reason. And some might not feel empowered to ask questions or feel safe enough to advocate for oneself. In addition, this time-limited setting in the emergency department can create additional disadvantages. Like, for example, some patients may experience difficulty in conveying their perspective when there's potential for some traumatic history that's contributing to the background context or adverse determinants of health. And if you imagine asking someone who otherwise don't have these risk factors and don't have disadvantages with socioeconomic status, and you ask, how was your day? I think the answer is a lot more simple than someone who has significant trauma and someone who is significantly disadvantaged in terms of determinants of health. And so all of these can be quite limiting for patients. And some patients, Indigenous patients in particular, may face stereotype threat, which is a phenomenon where someone feels actively compelled to avoid reinforcing perceived stereotypes. And some manifestations of the stereotype threat may give the provider the impression that the patient is disengaged, which may further impact quality of care that the patient ultimately receives. And trauma may affect, therefore, Indigenous patients disproportionately. And the impact of trauma can create numerous manifestations that's created, or that may be mistaken for psychiatric conditions, which may draw even more stigmatization. And so these manifestations may be things like dissociation, suicidal thoughts, difficulty setting boundaries, and loss of meaning. And these may be manifestations of trauma. And when these are not appropriately recognized as manifestations of trauma, sometimes it provokes conflict with care providers and hospital staff that then can lead to the patient being ejected for care or even banned from certain care settings, which can be, again, specifically disadvantaging to certain segments of the population. And trauma can also manifest in physical symptoms, and subconsciously this can inappropriately lower the clinical suspicion of providers when looking for physical causes by misattributing things that shouldn't be misattributed onto trauma and physical manifestations, when there could be another cause that needs, a dangerous cause that needs to be looked at. And so this can potentially inappropriately decrease our clinical suspicion. And so finally, the lack of trauma-informed practice can impair trust building, which may therefore lead to a reluctance to participate in providing a detailed history or working with you to give a physical exam. And so this might lead to an inadequate assessment, which may further increase the risk of misdiagnosis. And finally, impaired trust can lead to less ability to participate and engage in the care, which may finally limit the successful management of patients. So those are a number of different ways that trauma can contribute. I spoke primarily about Indigenous patients, but many of these phenomena apply to many extent to other members of the BIPOC community.
Thank you for that. I think this leads nicely into our fifth question, which is that there's a long-standing and ongoing history of trauma affecting some groups of patients more than others. It's kind of a question within a question. One, why has trauma-informed care come to the forefront of emergency medicine now? Two, how have systems changed to become more responsive to the needs of people in crisis? And Dr. Leo, I know you've been answering a lot in the past little bit, but I am going to start with you, and then we're going to hear from everyone on the panel their opinion about this.
What we were talking about, we'll further expand on that a little bit. The manifestations of trauma can cause a global impairment in our clinical process. And so it can inappropriately decrease our clinical suspicion, like we were talking about. It can limit the effectiveness of our history taking and physical exam and impair our assessment process. And finally, it can impair trust, which can decrease adherence, which leads to impairment in management. And so this impairment in the whole clinical process can contribute then to healthcare disparity, which is a phenomenon where the health system performs poorly for a select segment of the population. And so this can then translate into population-wide health disparity that we observe, like the 6-year gap in life expectancy between Indigenous and non-Indigenous peoples in Canada. And when we look at the life expectancy, sometimes we forget that, where does the 6 years come from? These come from specific interactions, each and every healthcare interactions where someone presents, and each missed opportunity. These cumulatively contribute to the 6-year gap in life expectancy. It doesn't magically happen somewhere at the end of life. It's a cumulative life course wounding that we unfortunately have a role to play in. And increasingly, providers are becoming aware of this phenomenon and are increasingly willing to incorporate cultural safety and trauma-informed practice principles into their work. And so this will certainly help us move in the right direction, but obviously much work remains to be done.
Thank you. Again, this is a big question. I think it would be great to hear from everyone. So Dr. Samsel, I will also want to hear your opinion about this.
Absolutely. So why emergency medicine, first of all, is because we are the port in the storm. We are the place that is always open. We see anyone, anytime, anywhere. There's no pre-booked appointments. There's no wait list to get into us or any of that kind of stuff. So we are the forefront of medical care in Canada and around the world. So these are our patients, and these are the people that we need to care for. And we often care for the most vulnerable of society just because they don't have the ability to access other parts of the healthcare system and social support systems. Why now? There's been a bit of a cultural awakening as to trauma-informed care and incorporating that within our practice is to once again reflect a consistency of emergency medicine as we are the canaries in the coal mine in a way as well. So we are reflecting a greater societal revolution in the sense that we are recognizing that things like traumas, systemic racism, systemic abuse that has happened within our structures and our history and our current times is harmful to people. So it's not just which beta blocker are we going to use today, which antibiotic is indicated. We have to treat the patient as a whole person. And so we are reflecting the culture in which we are going through at the time.
Thank you. That's great. Much appreciated examples. Dr. Heyman, can we get your perspective as well?
Sure. So I think in many ways, COVID has highlighted the why now. So I think sort of in this individualistic way, we've been able to ignore what's happening to people who experience marginalization and oftentimes have experienced trauma. And now we're in this place where we're looking at collective benefit, and we have to actually include everyone in our healthcare system when we think about COVID specifically, which I think has really highlighted a lot of these inequities. So, we know here in Toronto, rates of COVID are up to 5 times higher in racialized Canadians. You're 5 times more likely to die of COVID if you're homeless in Ontario. We saw early in April these huge gaps in COVID vaccination rates related to postal code, which is really just like a proxy marker for material deprivation. And especially with things like the vaccine campaign and people seeking care when they're sick, we can't ignore that past trauma at the hands of our governments and at the hands of our healthcare systems really impacts people's trust and willingness to engage with medicine in this way. And so I think we've really seen the need for community-led response and for addressing healthcare needs in a different way. And there's been a real impetus to think about how do we do that right now, maybe from a very cynical perspective, because if we don't bring everyone along, we're never going to get out of it in COVID. And so I think that's changed. It's really changed the framing. And maybe that's a very cynical view, but I think it has really, it's really highlighted a lot of what's been happening in Canada for a very, very, very long time. And I hope that we can continue to think about collective benefit in a very different way as we move forward from the pandemic.
Thank you. Rachel, in your position, do you have anything else you'd like to kind of add about this?
Yeah, I'd say, the global reckoning after George Floyd was killed, Black Lives Matter protests, also obviously the Me Too movement. It's really led to lots of different institutions starting to recognize to a greater degree the power dynamics and forms of oppression like racism, sexism, and how those things can play out in different settings, particularly in medical settings, but also, in policing, within schools, within lots of different institutions. And also recognizing that a lot of our current systems like police, like hospitals, can be traumatic or even dangerous for people experiencing crisis, and reforms or alternatives being created to support. So like what our organization is doing through the International Crisis Response Association, bringing together, I think at this point, close to 70 cities that are working on developing alternatives to police and hospital response to crisis. It's just not, insofar as hospitals and police may not always be necessary in order to resolve a crisis, and there may be more appropriate or other ways to provide support to people that are more trauma informed or that are actually connecting them with the resources they need. So I think that there's been a shift in that direction.
That's really awesome to hear. Thank you. Now moving on to our last question of the evening. As promised, some kind of actionable tips. How do we integrate this knowledge in the emergency department? I think the majority of us are, emergency physicians, perhaps emergency allied health, medical students, residents. Would love to hear from all of you about your kind of pro tips about how we can integrate this. Dr. Heyman, I'll start with you.
Sure. So I think I'll start with kind of an individual thing and then a structural piece. The individual thing, I think this is a hard ask, but like a pause and reflection before the use of physical restraint, if possible, or if you're receiving handover for someone in physical restraint, really figuring out like, what can I do to meet the needs of this person to help get them out of restraints as quickly as possible, recognizing that it's such a major point of re-traumatization for folks. And that's a lot. So I think the other piece I would say is if you have a patient advisory council for your emergency department, or you think about who makes the decisions, how do you include people who have lived experience of trauma, of marginalization, of poverty, of homelessness? How do you ensure that they're included in that representation and that they have a say in how your emergency department is built and how it functions, what the space looks like? I think that's a much bigger question, but that would be sort of one of the long-term goals and one of the big things that I think about a lot.
Thank you. Dr. Liu?
One practical item and one sort of more systemic. The practical is using cognitive forcing strategy. So assuming that trauma is present and making sure that we demonstrate to ourselves how we are, what actions we're taking to mitigate the effects of trauma in all of our conversations and all of our care. And the more systemic issue would be to consider building meaningful personal relationships with people of a variety of backgrounds outside your clinical work. And in the ED, we see people at people's most vulnerable state. And if we don't interact with people outside our own ethnic and social grouping, we risk developing stereotypical images that's informed by media and pop culture. And for many marginalized groups, these stereotypical imaging are quite negative and don't portray people in a dignified and capable light. And so this creates a risk that we can't imagine certain people as being dignified and capable, which may in fact subconsciously make us more likely to accept a lower standard of care, particularly in the highly demanding and challenging and resource constrained space that is the emergency department.
Thanks, those are great tips. Rachel, do you have anything to add?
Yes. So my other job when I'm not the director of a nonprofit is that I work at a hospital, a mental health hospital, training staff in trauma-informed de-escalation. One of the things that I have noticed in a lot of the trainings that I do is that staff tend to feel that other staff use restraints too often. They talk about this at every single training I do. What I do is sort of encourage people, it seems like a lot of you have doubts about how often you guys are using restraints. And like when you're in a situation where you're feeling uncomfortable with that decision, or really any decision you're wondering, is this the best course of action? Is this trauma-informed care? Is this what's helpful for the patient? Speak up. Say something, ask your colleagues, raise your concerns and have a conversation about it, because often you are not the only person feeling that way. And I say this particularly to medical residents, because when I've done training for medical residents, often they will say, because I am not the most senior person in the room, I feel uncomfortable speaking up, like maybe I'm wrong, maybe I don't know something. And I really just encourage folks, speak up, share your opinion, or even phrase it as a question, like asking, why are we doing it this way? That is really important in order to make sure, because often other people will be thinking the same thing that you're thinking, but they're afraid to say it also.
Thank you. That's a really great point. Restraints are definitely a big thing. It's come up time and time again tonight in our conversation. So definitely being mindful of that. Those are some great practical tips. And lastly, Dr. Samsel, do you have anything you would like to add?
Sure. So on a individual level, if you are seeing somebody who has disclosed trauma, so whether it's sex assault, intimate partner violence like I do, or any of the myriad of traumas that have been discussed tonight, try not to have the litany of people see this patient over and over again because they have to re-verbalize and rediscuss their story 18,000 times. So if you see someone that has a presenting complaint of something traumatic, or you've seen that they've been here a lot of times for traumatic type of interactions, this is the patient to go see yourself, or this is the patient to have somebody see and take ownership over. So it's not, the medical student sees it, who refers it to the resident, who reviews it with the fellow, who reviews it with the staff. And then this poor person is having to relive that trauma 4 times just for the information gathering portion of our interview and our care for the patient. The systemic thing that I would put in place for this is that you won't know if you don't ask. And we ask lots of personal things about people. We ask lots of uncomfortable things. We have lots of difficult conversations. But for some reason, we seem to be quite squeamish and we seem to be quite standoffish when it comes to approaching people with things that are uncomfortable to us. So traumas in particular. So if we ask somebody, do you feel safe at home? Who are you at home with tonight? Where are you going next? Those type of human questions that are going to demonstrate our care and our empathy for them, that helps to make this a normal part of our practice. And it makes all of these, everybody that has mentioned everything tonight, these cost $0. So this is not something that you have to get some big budget for, that you have to try to carve out some more blood from a stone to try to make this happen within your department. This is something that is a switch in your head to try to make somebody's interaction with the healthcare system and thus their downstream effects much, much improved.
Thank you. So that ends all of our formal questions that the panel had put together. Thank you, everybody, for your perspective. So going forward, we have some questions that have been posed in the chat here, as well as, I can hear them dinging in just now. Questions coming in from one of our medical students, Marika Moskalik, from Queen's University, who's interested in emergency medicine, is helping me moderate these questions. So thank you, Marika. Question 1. And I'm just going to put this out to everybody because I'm not sure that there's a good answer for it, but someone might know. One is, I have the impression that we are more cognizant of healthcare re-traumatization of patients in pediatrics. Is there better literature on peds emergency department culture versus adult emergency department culture and traumatization secondary to medical care? I'm just going to pose that out to if anybody feels comfortable putting in some information.
Just maybe, and I don't know if there's a way to ask a clarifying question. I think even just in preparation for this talk, I think the question of traumatization, like re-traumatization in the setting of physical trauma. So someone comes in, they fell off a roof, they're 5, how do we keep them feeling safe? Versus someone comes in, they fell off a roof while intoxicated with crystal methamphetamine, how do we keep them feeling safe? Yeah, I think the peds literature does a lot more of that than the adult literature. But there are some really good papers, including a recent one, I think in Annals in 2020, that talks specifically about in the adult trauma patient, how do we avoid re-traumatization? And oftentimes, not always, but I think the people's histories are a lot more complex by the time they get to be an adult. So, but I think a lot of the principles remain the same. I'm not sure if the person who asked the question wants to clarify as well, or if anyone else has any thoughts.
From sex assault and intimate partner violence land, the pediatric literature does describe this a lot more fulminantly than the adult literature, because when you're a child, it's not your fault. And so as you get older, that belief and that assumption goes away. And so it's a lot easier to be sympathetic towards and to be mindful of, getting those consent pieces along the way and making sure someone's comfortable when it's a 6-year-old that has this happen to them than a 36-year-old. So, because there's an assumption that something went wrong and there was a choice involved in somebody having this kind of issue, whatever it might be that they come to you for. So I think we just have to kind of, as much as the pediatric people hate being referred to as kids are just small adults, In this circumstance, adults are just big children. So we have to think about it that way, and it's not their fault that this stuff has happened. They are somebody that needs to be cared for regardless of the path that happened to get them there.
I think that's a great answer. Thank you both. I think that provides some additional kind of perspective about it. I like the adults are just big children. Another question, this is specifically for Dr. Heyman. Dr. Heyman, I have been seeing patients with COVID PTSD. Do you have suggestions of how to approach patients who are alone and isolated? Is there something we should be doing differently? Super interesting.
Oh my goodness. I mean, I think there's a lot. There's a lot there. I think like recognition of the profound impact the pandemic has had on people and their social bonds and their ability to access their usual supports is one big piece. This is not exactly, I think, what the question was asking about, but one thing that we've experienced in our emergency department with COVID, because the prevalence has been so high in Toronto, it's very hard for people to have accompaniment in the emergency department. And so even the experience of feeling very isolated while seeking care can be really hard for folks. So trying to ensure that if people have a support person, if there's a way to safely have them accompany them in the ED, it's tremendously helpful. And that person oftentimes can serve as an advocate. They can help get those comfort items. We've really lost that in the pandemic, and I hope we can see visitors and essential supports reintroduced to emergency departments, even to reduce the isolation in care. And then also, if you have the availability in your department for devices, for telephones, we've been very fortunate at UHN to have a project where we've been able to provide people with mobile phones. So if they're experiencing social isolation and they don't have access to a device, we can actually discharge them with a device as part of their discharge plan, and then provide them with some local support so that they can contact like through 211 in Toronto, and there's friendly neighbor programs, and recognizing that social isolation is as critical a component of their medical situation as, for example, their stats of 95% and likelihood of, potential for deterioration from COVID. I think that's really critical when we think about how to treat them.
Yeah, thank you for your perspective. That was an interesting question. And I think, also being in Toronto, feeling the same way about the families. And it's been the theme of many grand rounds at University of Toronto, our academic days, because it's been, I think, tough for everybody, families, patients, providers. So thank you. A couple other questions. It was mentioned that a patient's pain is often undertreated. How do we balance good pain control, and how do we manage pain when the psychosocial component is part of the physical pain? And I'm actually going to address this question to Dr. Liu, because I believe, you kind of had brought it up about the pain and sickle cell and the stems.
I think that was Dr. Heyman, I think, with the sickle cell stem, I think. But I'll take a brief stab at it. In terms of the pain in the context of psychosocial and other traumatic manifestations, I think sometimes this is where sometimes we can seek the strength from Indigenous methodologies and really listen to Indigenous methodologies. I'm myself a settler, not Indigenous, so I am not speaking from personal experience, but speaking basically summarizing some of the research that's available. For example, there has been good evidence that the engagement of elders or traditional healing methodologies actually improves both the physical response, the perception of pain, as well as decrease in suicidal ideation and increase abstinence from substances. And so there is tremendous benefit in looking at traditional, again, not to conflate the issue of pain with substance use, but I don't mean to introduce that in there, but just to think about the fact that pain is multimodal and it can be spiritual as well. And so engaging different ways of knowing, I think, is one way. The other is that we may need to examine our own stereotypes as well, because sometimes we have a heightened perception of risk around misprescription of pain medications. And so the statistics does tell us that we probably underprescribe to all racial minorities in North America, not specifically Indigenous patients, but with Indigenous patients, the stereotype around dependency is much higher. And so we will have to really question, where are we getting the information from? What is our suspicion when we think that we are risking inappropriate prescription? Where is that fear coming from?
Thank you. And our last question, I know it's 8 o'clock, so we're going to cut it off right after this question, is how do we help patients who have experienced trauma in a healthcare setting? I've heard from patients who cannot imagine ever feeling safe in an emergency department. How do we help them? And I'll just direct this to anyone who feels comfortable answering it.
I'll take a quick whack at the beginning of this, is that, so be what you want to see. So people have been traumatized by us. There is no two ways about that. But if somebody is going to come back to us, we have to regain their trust. We have to be what they need and be what they need to see. So we need to be welcoming. We need to try to accommodate as best as we can, knowing that emergency departments are not overflowing with resources and space most of the time, but we're going to try to meet them where they are. We're going to provide culturally appropriate care. We're going to do our homework so that we can address our biases. So we're basically going to be the place where we can see somebody landing softly and being able to start to build that foundation of trust again. Because it's built brick by brick, and if you put it off as somebody else's problem, it's never going to get done.
Thank you. So being mindful of everyone's time, it is 8:01 p.m. We are, almost on time. I just wanted to say thank you so much, everyone, for attending tonight's trauma-informed grand rounds. And thank you to our amazing panelists for answering our questions as well as the audience questions. I really think that everyone has something to take home with them tonight after the session. And yeah, we really appreciate it. Thank you. And with that, everyone have an awesome night. I know it's nice here in Toronto. Hopefully it's nice wherever you're coming from. Enjoy the weather.